Welcome again, all of you, to this 15th NHS Alliance Annual Conference. This is the conference of primary care, for primary care, and by primary care. And I'm so pleased to see all of you here today, because today your strong values, your determination, your supportive relationships are so important to the NHS today, and they're never more evident and obvious than in this room. So, to the imperatives of the present. The first is that clinical commissioning should succeed, that it should deliver better services and health for our patients. And that's going to require great leading clinicians working with great leading managers and great providers working with them. So, what are those harbingers of doom who told us that we would be unable to find those leaders, that they would not want to lead, that they wouldn't be up to leading? And how wrong were they? Because we now have 211 heroic men and women and many others supporting them, ready to meet the challenges ahead. NHS heroes in every sense. And those leaders will need the wisdom of Solomon, the courage of Nelson, the determination of Mandela, and the humility of Gandhi. And that is because the lessons of the past tell us that a centralist, secondary care dominated system run by a managerial hierarchy will not relinquish its grip without a fight. Those clinical commissioning groups and their leaders will also need strong champions to give them headroom. And that is why the commissioning arms of NHS Alliance, NAPC and NHS Confederation have come together as NHS clinical commissioners. With most clinical commissioning groups now being members, we can provide a strong and unified force for them. So from now on, anyone who wants to mess around with CCGs is going to find themselves staring up the wrong end of a gun that this time has got 3 barrels. Because this time we're going to ensure that the ideals that you have fought for actually happen. This time there will be no replay of the broken promises of the past. And I hope and I believe the NHS Commissioning Board will play an important role in making this happen, perhaps as a thanks for our role in its creation, because it must become the grand protector of clinical commissioning groups and their leaders, just as the chief of our health authority during the locality commissioning days told me that she was there to cover our backs and support our difficult decisions. The current language of the board is exactly right, with phrases such as assumed liberty. But these words must now translate into action. And that is why last week, NHS clinical commissioners announced that we will be undertaking 360-degree appraisal of the National Commissioning Board. Each year, we will collect appraisals from each clinical commissioning group of the National Commissioning Board and of its local office. And from those appraisals, we will produce a national report which we will share with the National Commissioning Board, and then we will publish the results, alongside proposals as to how things can be improved. And that is because there can be no same old in the relationship between the centre and the new clinical commissioners. No reversion in type from Grand Protector to Grand Inquisitor. And what applies to relationships between CCGs and the Commissioning Board equally applies to every clinical commissioning group in its relationship with frontline clinicians and practices. Because that was the other missing link of the past. Clinical commissioners, as a second imperative, must now work as hard as possible to ensure that their frontline clinicians are motivated, effective, and dare I say it, yes, happy, enjoying their role as the new commissioners. Because those GPs, nurses and other allied professionals have real legitimate concerns. Some feel they've got too much on their hands already. Some feel that they will be blamed if services are less than expected. Some fear that their relationship with patients will be compromised. And others suspect that this is the beginning of widespread NHS privatisation. We must answer these fears, explain and show how every clinician now has the chance to make a real difference for every patient. It was George Bernard Shaw who said over 100 years ago, "Until the medical profession becomes a body trained and paid by the country to keep the country in health, it will remain what it is at present, a conspiracy to exploit popular credibility and human suffering." Clinical commissioning marks the end of that conspiracy, if there ever was one. A promise that clinicians henceforth will be able, enabled and committed to keep the country in health. And the third imperative is to ensure that the patients and the clinicians make as fearsome partnerships as commissioners as they do in the consulting room. Partnerships that will enable local people and clinicians in clinical commissioning groups and also in health and wellbeing boards to literally shake the floor beneath the trembling feet of any centralist left standing. Because in future, patients and local people must be more than critical friends and co-planners. They must become an intrinsic part of our system for creating better health and care. And so, from the present to the future, the first task of clinical commissioning groups and their clinicians will be to redesign local services in health, to enable the frail elderly and those with long-term disease to be looked after within their communities, to enable and redesign things that have so persistently failed to materialise under the old order. And to do this, clinical commissioning groups will need to become demolition experts, removing the mines, the obstacles and the red tape that prevent them securing better services and outcomes, enabling good providers to provide even better and going elsewhere when they can't. And we're already beginning to see this transformation witnessed in a document that we produced earlier this year, Clinical Commissioning in Action. Yet, however much we redesign our services, however cost-effective we make them, we will eventually hit the buffers of unaffordable cost, deteriorating quality, or reduced availability. And that means we now need to think bigger, wider, and more ambitious. And I'll explain. In the USA, the life expectancy of the poor white population is already going down, and we in the UK are set to follow them. And the NHS is not going to stop that with just a few more no-smoking clinics or obesity clinics, by tablets or by operations. The NHS needs to become a national health system with clinical commissioners, health and wellbeing boards, and those at the heart of delivery being catalysts of health on every street corner, in every supermarket, on every inner city estate, and in every rural village. Public health will need to get its hands dirty. Every patient and clinician will need to play his or her part in improving personal health, ensuring that resources are best used to best effect, maximising well-being and resilience, and breaking new boundaries, involving new legions of health trainers, health advisors, community workers, and volunteers, supporting local initiatives from fishing clubs in Newcastle to dementia-friendly towns in Crawley, initiatives that have all too often been ignored in favour of short-term targets and cash-strapped services. But even that will not be enough. Patients will still remain over-medicalised, over-professionalised, over-hospitalised. And then we need to ask ourselves, do we really want a fair and equitable health system? And if we do, we need to re-engineer a totally new relationship between the NHS and the people it serves. A relationship, a new relationship, that reflects and exploits that rich seam of goodwill and giving that lies behind the very idea and concept of an NHS. And that will mean reigniting the altruism that lies beneath the skin of every clinician, however scarred by life's events, reinvigorating the professional ethic that wants to make a difference, releasing that pent-up altruism so endemic in the population and so visible among those Olympic volunteers, and so visible every day in my own surgery, from the patient that brings in the elderly next-door neighbour to the next patient that allows the sicker patient who is coming after him to go before. The NHS must become, in short, more than just a service, a consumer service. From now on, it must be a partnership, a national health partnership. And only if we can do that can we maximise the co-production between clinician, patient and population, and deprofessionalise and demedicalise wherever possible and appropriate. Can we release a spirit so common in our churches, our schools, our lifeboats and our fire services, but not common enough when it comes to health? And only if we can develop this new social contract between patients, people, professionals, managers and the service can we begin to reach the holy grail of health-creating communities, and thus maintain the vision of a service that is free at the point of delivery. And that will mean rewriting the NHS constitution, a better and more honest balance between rights and social responsibilities. Otherwise, the harridans and harpies of me first, don't care, and it doesn't matter because it's all free, will destroy the spirit and the reality of our NHS. And that's the debate that we must start here at this conference. What will primary care and the future NHS look like? Next March, we will gather together all the words and aspirations of this conference and the conversations that follow to produce a piece of work in partnership with the Nuffield Trust and the King's Fund that will lead the future, a manifesto for that future. Because standing on the brink of this new world has helped us at NHS Alliance to clarify our own vision for the future. I've been very proud to have been chosen to lead the Alliance for the past 15 years. But what are the next 15? Put simply, you could say that we've dealt with commissioning. It's now time to look at provision. Because excellent provision relies, or excellent commissioning relies on excellent provision. And these ambitious reforms will only deliver if we can successfully harness the enthusiasm and the commitment of frontline clinicians and managers and the wider providers of services within primary care. And in future, as NHS Alliance, we want to represent the people and the organisations whose services commissioners will be proud to commission. And in our new role, the Alliance will continue with the same values, the same determination, and the same passion. A force to be reckoned with, as quoted by 3, at least, previous Secretaries of State. Championing innovation and patient involvement. An NHS that is fair, as we said in our very first document, fair to patients, but also fair to those who look after them. So much so is our new emancipating message that every member, whether individual, practice or primary care, will in future be free to decide what membership fee to pay, depending upon what you think we are worth. Symbolic of a new culture and behaviour in the NHS that we mean to create, illustrated in the new Alliance badge with its partnership logo. And we do value our partners, and I want to make mention here of our commercial partners too, particularly MSD, our main sponsors today, Abbott and Novodisc. I hope that we can continue this great movement forward together in the sort of partnerships, supportive partnerships that we've had to date. And if you want any more details of that, you'll find this in your conference bags. So, today, whether you're an individual clinician, or you're a manager, a provider, or a commissioner, you carry a very huge burden indeed. To overcome the ill health, the unhappiness, and all the other negative effects that our current system creates. The deprivation, abandonment, bullying, and abuse. The stark architecture, chemical substances, moral pollution, violent video games, trash food, existential disconnect, near zero attachment, feral overclass greed, mindless TV, loss of hope, control and attachment, the isolation and the exclusion. As a National Health Service, we must go beyond being simply a repository for the downstream consequences of all of these, just patching people up. From now on, as a national health partnership, we can begin to do something about them. And to do that, we will need to renew our passion and determination, create an NHS turned NHS partnership that will restore a sense of human worth, then a sense of meaning, then of hope. An NHS that cares as well as does, that makes healthy, supportive communities out of alienated and fragmented ones, that spreads the word that giving is better for your own health and for everyone else. And these things will not happen as a result of central edict or regulation. They must bubble up and explode as our message of exasperation and liberation, part of a new unstoppable relationship between clinicians, managers and local people, all committed to the health of their communities, a health revolution that will never see the voice of patient or frontline clinician ever ignored again. And we will not achieve this by the banging of little fists. In the word of T.S. Eliot, we must leave behind the conscious impotence of rage. Also, in his words, we must have the strength to face the moment in its crisis. I'm not a poet, but I know we must, or we're bust. In the same poem, T.S. Eliot challenges us to ask, do I care and do I dare? Do we care? Do we dare? That's the question that we all face today. We must overcome the apathy and fear among our fellow clinicians. Together, we must seize power against the broken promises, the silly orders, the cant, and the cynicism of the past. We must regroup and become unstoppable, progressive, terrifyingly positive, a force for real reform rather than simply disorganisation, a force that will reignite that rage that enables radical things to happen, the force that we created when we fought and won the battle for clinical commissioning. That is the revolution that the NHS now needs, that every patient needs, a revolution that will fully enable clinical commissioners to redesign their local services, a revolution that will re-energise local health and create healthy communities, a revolution that will re-engineer an entirely new relationship between our people, our patients, our managers and our clinicians. We must do all these three things together. We must do them now. We can and we will. And then, and only then, perhaps at long last, we can go home.